Welcome to the deep dive. Today, we're tackling a topic that, well, it might conjure images of old war films. Gas gangrene. And while its historical ties to battlefields are definitely there, the reality of where and how it occurs today, well, it might surprise you.
It often does.
We've got the chapter titled Gas Gangrene from the textbook Hyperbaric Medicine Practice as our guide today.
Right. And our goal in this deep dive is really to explore this serious infection thoroughly. We want to break down what gas gangrene is,
Okay.
the ways it develops, which are quite fascinating, frankly, and how clinicians spot it. And crucially, we'll look at the role of hyperbaric oxygen therapy.
Right, its established role in treatment.
Exactly. All based on the current medical understanding, as laid out in this text.
Perfect. And here's something to think about right away. We might picture soldiers from past wars, but gas gangrene, it's actually more common now in, civilian life after accidents and maybe surprisingly sometimes after surgery.
That shift is quite significant.
Okay, so to start us off, what exactly is gas gangrene?
Fundamentally, it's a muscle infection. Myonecrosis is the medical term, and it's nasty. It spreads very rapidly and can be deadly.
And it's caused by Clostridium bacteria.
That's right, bacteria from the Clostridium family.
The name itself, gas gangrene, seems pretty specific. Is there actual gas involved?
Yes, there often is. As these bacteria chew through tissue, they frequently produce gases. It's a byproduct of their metabolism in that environment.
You mentioned the history, the combat connection.
Right. Contaminated wounds on battlefields were historically a huge factor, no question.
But it's less common there now.
Oh, significantly.
Sure.
The striking thing is how much less common it became in, say, the Vietnam War for American troops, compared to what was being reported in just one city, like Miami, during a similar time frame in civilian life.
Wow, that really paints a picture. It speaks volumes about changes in wound care, maybe, or the types of injuries.
Both, likely. It forces us to look at how we encounter this disease today.
So within this Clostridium family, are there main culprits?
Yes. Clostridium perfringens is the big one. It shows up in about 80% of contaminated wounds that actually develop into gas gangrene.
80%, okay.
But it's not alone. There are others, less frequent but still important. C. edemations, maybe 40% of cases. C. septicum, around 20%. And then a few others, like C. histolyticum, C. bifurmentans, C. phalanx. They make up less than 10% combined.
So a whole gang of them, potentially. What makes them so dangerous once they're in the body?
It really comes down to toxins. These bacteria are like little toxin factories.
Okay.
They can produce over 20 different types of exotoxins.
Right.
And get this, 6 of those are known to be lethal.
6 lethal toxins.
Yes, which is why the damage is so profound and spreads so quickly.
Yeah.
In fact, some experts describe gas gangrene less as a simple infection and more like a severe intoxication caused by these bacterial poisons.
An intoxication. That's a strong way to put it.
It emphasizes the role of the toxins over just the bacteria multiplying.
Let's focus on the main one then, Clostridium perfringens. What are its key toxins doing?
The alpha toxin is really its signature weapon. Phospholipase C is the technical name. Finding it is a big diagnostic clue.
What does it do?
Well, essentially it dissolves the outer layer of our cells, the membrane,
Okay.
which messes up their function, makes them fall apart. And crucially, this helps the bacteria because it prevents our immune cells, the first responders, from getting to the infection site.
It blocks the defense.
Exactly. Plus, it triggers tiny blood clots right there in the small vessels.
Which makes things worse.
Definitely. It cuts off the blood supply even more, leading to more tissue death. There's a really neat study in mice. They made a version of C. perfringens that couldn't produce alpha toxin.
Yeah.
It basically became non-virulent, harmless. But when they restored its ability to make alpha toxin, it was fully dangerous again. Shows how critical that one toxin is.
So alpha toxin is a major player. What about the theta toxin you mentioned earlier, perfringolysin O?
Right. Theta toxin, it works alongside alpha toxin, kind of synergistically.
Oh.
It ramps up the breakdown of red blood cells hemolysis, which adds to the tissue damage. And it can contribute to a dangerous state called warm shock.
Warm shock.
Yeah, where your blood vessels relax too much, blood pressure drops. Even though the heart is actually pumping harder, it's a bad sign.
A dangerous duo then. Are there other toxins involved too?
Oh, yes. Alpha toxin might be the star, but C. perfringens has accessory toxins too, like kappa toxin, which breaks down collagen, part of our connective tissue,
Okay.
and others that can mess with the immune system, damage DNA, even interfere with blood group factors. It's like a coordinated chemical assault causing that incredibly rapid tissue destruction.
A whole suite of weapons. Once these toxins are out there, are they just permanently active?
Thankfully, no. Alpha toxin, for example, actually becomes inactive relatively quickly within about 2 hours after it's produced.
Oh, okay.
It also tends to bind to tissues and get neutralized. And, the body does try to fight back. The toxins can get carried away in the blood and detoxified by the liver and kidneys.
So it's the ongoing production that's the problem.
Exactly. The severity really hinges on that initial insult and the continuous local production of alpha toxin, which just keeps going as long as those low oxygen conditions persist where the bacteria are thriving.
Okay, that gives us a good picture of the bacteria and their nasty toxins. So how does gas gangrene actually get started? What conditions need to be right?
Right. The textbook makes a really important point here. Just having Clostridium bacteria around isn't enough.
Okay.
Estimates suggest maybe 30% of traumatic wounds get contaminated with C. perfringens spores, but the actual disease, gas gangrene, develops in less than 3% of those.
Less than 3%, so it's not inevitable at all.
Not at all. It's really a disease of opportunity.
Right.
You need two things. The clostridial contamination, which is fairly common,
Right.
and this is the key, a significantly lowered oxidation reduction potential in the wound. Basically, a severe lack of oxygen energy.
Low oxygen, that's the trigger.
That's often the critical limiting factor. It's like you need to fuel the bacteria, but you also need the right environment, low oxygen, for the fire to really catch and spread.
And what causes that critical oxygen drop in the tissues?
The main driver is usually a disruption of the local blood supply, ischemia.
Lack of blood flow.
Exactly. Which leads to hypoxia, lack of oxygen in the tissue itself. This often happens from trauma, like penetrating injuries that physically damage blood vessels.
Makes sense.
But, ironically, sometimes our own attempts to help can make it worse. A tourniquet left on too tight, or a cast, or even tight dressings.
They can cut off circulation too.
They absolutely can, further restricting blood flow and creating more dead, oxygen-starved tissue.
The text specifically mentions high-velocity missile wounds. How did they create this environment?
Well, things like bullets or shrapnel traveling at high speed dump a huge amount of energy very quickly into the tissues. The entry wound might look small, but the projectile causes massive internal damage as it passes through, fracturing bone, tearing muscle, shearing blood vessels far from the entry point.
So widespread internal damage.
Exactly.
Yeah.
And many muscles have sort of a single main blood supply without many backup routes. If that main vessel gets damaged, the circulation can be almost completely cut off.
Bleeding quickly too.
Ischemia, hypoxia, and then muscle death, necrosis, which is the perfect low oxygen incubator for Clostridium. The literature suggests vascular damage is present in the vast majority of traumatic gas gangrene cases.
Okay. What about in surgery? How does it pop up there sometimes?
In postoperative cases, it's often seen after GI surgery, especially in patients who already have poor circulation from things like atherosclerosis or diabetes.
Okay.
Gas gangrene developing in the trunk area in those patients can be a strong warning sign of a bowel leak.
A leak from the surgery site?
Potentially, yes.
Mm-hmm.
Also, there's post-injection gas gangrene that's been linked sometimes to using epinephrine.
Epinephrine, the adrenaline drug.
Yeah. It constricts blood vessels. So if it's used during wound cleaning or closing, it can actually reduce blood flow further in that area. That's why it's generally contraindicated for debridement.
That makes total sense. You don't want to starve the tissue of oxygen even more. Any other risk groups?
Yes. Intravenous drug users are at higher risk.
Why is that?
Repeated injections cause trauma and infection, leading to scar tissue formation. And scar tissue often has poor blood supply, poor oxygenation.
Creating that perfect environment again.
Precisely. It's also important to know it's not always linked to obvious trauma or surgery. There's something called occult, or atraumatic gas gangrene.
Meaning no clear injury.
Right. And C. septicum is often the culprit there. These infections frequently spread from lesions in the GI tract, especially in people with conditions like colon cancer or weakened immune systems.
Interesting.
And there's some thought that because C. septicum might tolerate oxygen a bit better than C. perfringens, hyperbaric oxygen therapy might be, well, perhaps slightly less effective against it. Still used, but maybe less dramatically effective.
So quite a few ways to end up with that critical low oxygen state needed for gas gangrene. Okay, let's shift gears. What does this look like clinically? What would a doctor see?
Well, the textbook brings up Altemeyer's classification, which is still useful. There are a few forms. The most serious, the one most people think of, is clostridial myonecrosis with toxicity. Classic gas gangrene.
Okay.
It develops fast, usually within hours, maybe a few days after the injury. And a really key early sign is pain, severe pain.
More pain than you'd expect from just looking at the wound.
Exactly. Pain that seems way out of proportion to the apparent injury. That's a major red flag.
Okay. Pain out of proportion. What else follows?
The area swells up, often quite dramatically, from fluid buildup edema. The skin gets tight, might look pale initially.
And then?
Then, often quickly, the skin color changes. It can go bronze, then darker and darker as the tissue underneath dies. You might see blisters forming, filled with fluid blebs and bullae.
Sounds awful. What about fever or blood pressure?
Interestingly, unless there's another infection mixed in, patients often don't have a super high fever at first. And their blood pressure might hold up initially.
Wow.
But their heart rate is usually way up. Tachycardia that's out of sync with the fever. Also, sometimes patients seem weirdly calm or detached, even though they're obviously very sick. La belle indifference, it's sometimes called.
Wow. Severe physical signs, but a strange mental state. That's unsettling.
It really is.
What about the gas part? Any specific signs there?
Yes. The drainage from the wound is often thin, watery, maybe bloody, serosanguinous. And it can have this characteristic smell, sometimes described as sweetish or mousy, unless other bacteria muddies the picture.
There are bubbles.
You might feel crackling under the skin that's called crepitus, or see gas tracking through the tissue layers on an X-ray.
But is gas always present?
That's a crucial point. No, it isn't. Gas can be absent in a significant number of confirmed cases, so you absolutely cannot rule out gas gangrene just because you don't feel or see gas.
Good to know. Don't rely on the gas.
Right. The text also mentions arterial gas embolism, AGE, which is related in that gas blocks blood flow, but it's a distinct condition.
Okay, so that's the classic toxic picture. What were the other forms Altemeyer described?
There's localized clostridial myonecrosis, usually happens after non-sterile injections. The infection stays put more or less at the injection site. Systemic toxicity is minimal or absent.
But you still need to watch it closely?
Absolutely. You have to monitor for any sign it might be spreading or becoming toxic. Then there's clostridial cellulitis without toxicity, sometimes called a gas abscess.
What's that?
Here the infection is limited to the subcutaneous tissue under the skin, but it hasn't invaded the muscle itself. It's generally milder, drainage might be enough, but again, you watch carefully for toxicity.
And the last one?
Clostridial cellulitis with toxicity. This one's rare. It's cellulitis, but it acts like the aggressive myonecrosis with severe systemic toxicity. Prognosis is just as grim if not treated fast.
It really sounds like suspicion and speed are critical across the board, especially with the classic form. Which brings us to hyperbaric oxygen. This is fascinating. What's the evidence for its role?
There's quite a bit of evidence, actually, both from lab studies, in vitro and in vivo animal models, and from clinical experience over decades.
Like what?
Well, a key early study was by DeMello and colleagues. They used dogs, induced gas gangrene experimentally, and compared treatments. Hyperbaric oxygen, antibiotics, surgery alone, and combined. The clear winner. The highest survival rate by far was when they used all three together.
Surgery, antibiotics, and hyperbaric oxygen.
Exactly. Significantly better than any one or two treatments alone. They also showed hyperbaric oxygen could slow down the germination of C. perfringens spores.
So it stops them from waking up and causing trouble.
It helps, yes. And other studies back this up.
What are the specific ways hyperbaric oxygen helps fight this? What's the mechanism?
There are several mechanisms at play. Animal studies, like those by Hill and Osterhout and others, consistently showed better survival with hyperbaric oxygen.
Okay.
A really crucial finding came from Van Unnek. He showed that exposing Clostridium to oxygen at 3 times normal atmospheric pressure, 3 ATA, actually stops it from producing that critical alpha toxin.
It shuts down the toxin factory.
Pretty much. Hill and Osterhout also found high oxygen levels could overcome catalase, an enzyme bacteria used to protect themselves from oxygen damage in dead tissue. Kay showed hyperbaric oxygen could even directly kill the clostridial organism.
A direct bactericidal effect.
Yes, and Stephen's work showed that even moderately increased oxygen levels suppress bacterial growth and higher levels suppress toxin synthesis. So it hits the bacteria and their weapons from multiple angles.
Hinders spores, stops toxins, kills bacteria, bypasses defenses. That's quite a list. What about its use in people? How long has this been applied?
It really took off in the 1960s. Between about 1961 and 1978, there were reports on over 1,200 cases treated with hyperbaric oxygen.
On results.
Looking back at that data, the overall mortality was around 25%. But if you look specifically at deaths directly caused by the gas gangrene itself, it was closer to 15%.
That's still quite high.
It is, but here's the kicker. When patients got hyperbaric oxygen within 24 hours of diagnosis,
Yes.
the disease-specific fatality rate dropped to just 5%.
5%, that's a massive difference.
Huge. And since then, countless more cases have been treated worldwide.
Yeah.
It took time, but hyperbaric oxygen is now a well-accepted adjunct therapy by clinicians familiar with it.
An adjunct, meaning part of a larger plan.
Absolutely. It doesn't replace surgery or antibiotics.
Right.
These patients need full-on intensive care. It's a team effort.
Right. Okay, let's put it all together then. How do doctors approach diagnosis and treatment today, integrating hyperbaric oxygen?
Well, like we said, that first clue is often pain out of proportion to the injury.
Got it.
Depending on how long the infection has been brewing, you might see those signs of systemic illness, the toxicity.
And the gas.
Gas in the tissues can be found, maybe by feel or X-ray. But remember, it's not required for the diagnosis. Looking at tissue samples under a microscope can show the dead muscle, the bacteria, and interestingly, often a lack of the usual inflammatory cells you'd expect.
Because the toxins keep them away.
What's the thinking? Yes.
So lab tests help, but it sounds like you can't wait for confirmation.
You really can't. Time is absolutely critical. Once that tissue destruction gets going, the outcome depends heavily on how fast you get in there surgically. The decision to treat is often clinical.
Based on suspicion.
Exactly. Often, the definitive diagnosis is only made during the surgery itself, when the surgeon sees the state of the muscle tissue.
And the goal of that surgery.
Remove all the dead necrotic tissue, but try desperately to save everything that's still viable that has a blood supply. Minimize the long-term damage.
And this is where early hyperbaric oxygen helps the surgeon.
Precisely. Starting hyperbaric oxygen early can help halt the spread, draw a clearer line between dead and living tissue, making that debridement potentially less extensive.
Okay, so what's the overall strategy? You suspect gas gangrene.
Right. The strategy emphasizes hyperbaric oxygen as a key partner to surgery and antibiotics. For high-risk traumatic wounds, even minor ones, especially near water, assume contamination. Clean them thoroughly, get all dead tissue and foreign stuff out, irrigate well.
But gently.
Yes, avoid harsh scrubs with certain detergents. And usually leave these wounds open initially, inspect them frequently, maybe close them later if they look clean and healthy.
What about patients having surgery who might be at risk, like that bowel surgery example?
Meticulous sterile technique is number one. Be careful with cautery. Bipolar is generally preferred over monopolar as it causes less tissue damage. Tie off larger vessels with sutures. Close tissues without tension, and check those wounds daily after surgery.
So vigilance is key. When does hyperbaric oxygen usually start in this process?
For limb infections, surgeons often need to do fasciotomies, first cutting the fascia to relieve pressure. But beyond the initial cleanup, hyperbaric oxygen is crucial. The recommendation often is to give at least 2 hyperbaric treatments before the main surgical debridement.
Why before?
To try and stop the infection's spread, stabilize the patient, make surgery safer, and as we said, help define that line of demarcation for the surgeon.
Then surgery, then more hyperbaric?
Yes. After debridement, continue the hyperbaric therapy. Keep checking the wound daily, debride more if needed. The last hyperbaric treatment is usually after the patient's systemic toxicity signs are gone. Then you watch closely for any recurrence.
And if it comes back?
Restart hyperbaric oxygen immediately.
Okay. What about antibiotics? Still a cornerstone, right?
Absolutely. Penicillin G is still the first-line choice, usually high-dose IV for about 2 weeks. But other drugs work well in the lab against Clostridium, clindamycin, tetracycline, chloramphenicol, metronidazole.
What if someone's allergic to penicillin?
Chloramphenicol or metronidazole are options. If you suspect a mixed infection with other types of bacteria, you might add aminoglycosides or newer cephalosporins or chloramphenicol.
Any interesting developments there?
Well, some animal studies suggest combining clindamycin with penicillin might be good. Clindamycin alone also did well in animal models, possibly because it might also inhibit alpha toxin production.
Ah, another mechanism.
And tetracycline seems to shut down toxin synthesis pretty quickly too. But it's important to stress we don't have large human trials comparing all these specific antibiotic regimens head-to-head for gas gangrene. So a lot is based on lab data and clinical experience.
Understood. The text mentioned antitoxin. Is that used?
Polyvalent gas gangrene antitoxin? No, none.
Why not?
Its effectiveness was never really proven, and it came with a high risk of severe allergic reactions, like serum sickness or even anaphylactic shock. So it's off the table.
Makes sense. What about other support? Tetanus shots? Blood?
Definitely aggressive tetanus prevention, both immune globulin and the toxoid vaccine. Blood transfusions, well, use whole blood carefully for acute loss. Aim for a hematocrit around 30–35% after fluids are restored. Filter it to prevent lung issues. Use components like plasma or platelets if needed for specific clotting problems.
Getting patients to a hyperbaric chamber quickly sounds vital. How does that work logistically if the Front Hospital doesn't have one?
Yeah, time matters. If the local hospital can't provide it, transfer to a center with a chamber should happen ideally within 24 hours. You need to coordinate with the hyperbaric physician at the receiving end.
And transport.
Fastest way possible. Often means an air ambulance if it's, say, over 100 miles away.
And the treatment inside the chamber, what's the typical protocol?
It generally follows established protocols. Usually, pressure is increased to the equivalent of 66 feet of seawater. That's 3 ATA. Some use 49.5 feet, 2.5 ATA, which is seen as the minimum effective pressure.
And the oxygen?
The patient breathes 100% oxygen for about 90 minutes per session, usually through mask or via ventilator if they're intubated.
90 minutes straight.
Often broken up with short air breaks, maybe 5 minutes, to reduce the risk of oxygen toxicity to the central nervous system.
How many treatments?
Typically 3 treatments in the first 24 hours, maybe spaced out, or the first 2 closer together if the patient is really sick. Then usually 2 treatments a day after that until the toxicity clears up. Often ends up being around 7 treatments total, minimum of 5.
And the staff inside?
The patient usually comes straight back to normal pressure, but any attendants inside the chamber with the patient need to follow specific decompression schedules to avoid getting the bends. And everyone's watching closely for signs of oxygen toxicity, ready to interrupt the O2, give air breaks, adjust pressure if needed. It's carefully managed, especially if the patient's on anti-seizure meds.
Wow, complex. Beyond the chamber itself, what other medical care is critical?
Oh, managing fluids, electrolytes, and the body's pH acid-base balance is huge. Constant monitoring, adjustments to keep things stable, maintain blood volume to help flush toxins and perfuse tissues.
How do they monitor that?
Urine output, central venous pressure lines, clinical signs. Careful choice of IV fluids. Checking electrolytes and pH frequently, maybe every couple of hours in severe cases. Treating acidosis with bicarbonate if needed. Checking blood sugar is vital too. Rule out undiagnosed diabetes. Manage known diabetes, which can go haywire with infection. High potassium from tissue breakdown needs managing. Low potassium needs preventing, especially with certain heart meds.
And between the hyperbaric treatments, back in the ICU?
Yes, continuous ICU monitoring.
Yeah.
If they're ventilated, you actually want to keep the oxygen level, FiO2, between hyperbaric sessions as low as possible, like normal air levels if feasible.
Why is that?
To minimize the risk of lung damage from prolonged high oxygen exposure, pulmonary oxygen toxicity, you only increase it if their blood oxygen really drops. Keep watching fluids, electrolytes, immune status. Positive pressure ventilation is common.
It really sounds like a constant, intensive balancing act. The textbook mentions complications too. What are the big ones to worry about?
Yeah, even with the best care, things can go wrong.
Yeah.
ARDS, acute respiratory distress syndrome, is a major one. Lungs fill with fluid, gas exchange plummets. Trauma, microemboli, oxygen toxicity can all contribute. Manage the cause, fluids, ventilation.
Okay, what else?
DIC, disseminated intravascular coagulopathy. The clotting system goes haywire. You can get both bleeding because platelets and clotting factors are used up, and clotting because tiny clots form everywhere. Treat the infection first, maybe heparin, maybe clotting factors. It's complex.
Kidney problems.
Oliguria, low urine output, and acute renal failure can happen. Hyperbaric might sometimes help, but dialysis might be needed. Kidney failure doesn't mean you stop hyperbaric, though.
Heart issues.
Myocardial irritability, those clostridial toxins can affect the heart muscle, causing arrhythmias, so continuous cardiac monitoring is essential.
And clots.
DVT, deep vein thrombosis. Risk is high with immobility, trauma, surgery. Prevention is key: blood thinners, leg elevation.
Anything else?
Fat embolism, especially after long bone fractures, can be a risk during transfer. Immobilize limbs carefully. And again, arterial gas embolism is a possibility.
That's a serious list. Really drives home the severity and the need for that comprehensive care. Okay, as we wrap up this deep dive, what are the main takeaways from the textbook on gas gangrene?
Well, the text really concludes that despite better wound care overall, gas gangrene hasn't gone away. It's just shifted its primary location, from the battlefield to civilian trauma and surgical settings.
Yep.
And historically, the only real option was radical surgery. Antibiotics helped, but didn't fundamentally change the need for aggressive debridement initially.
Until hyperbaric oxygen came along.
Exactly.
Yeah.
Its effectiveness, really demonstrated starting in the 60s, was a game changer. Because it helps neutralize those toxins so quickly, it often allows for less mutilating surgery. It reduces morbidity.
But it's not magic bullet.
Absolutely not. The text stresses, hyperbaric oxygen is not a standalone cure. Success depends entirely on that coordinated approach: rapid diagnosis, intensive supportive care, vigilant monitoring, prevention where possible, and the integration of surgery, antibiotics, and hyperbaric oxygen.
A truly multi-pronged attack needed for an aggressive adversary. So, quick recap. Gas gangrene, severe muscle infection, Clostridium bacteria, potent toxins, needs low oxygen. Surgery and antibiotics are vital, but hyperbaric oxygen is a crucial partner, fighting the bacteria and their toxins directly.
Right. And what really stands out to me is that shift we discussed from combat zones to, well, everyday life accidents in hospitals. It shows how diseases evolve in context. And the sheer complexity of those toxins, it's a reminder of how intricate infectious diseases are.
Absolutely. It makes you appreciate how advancements like refining hyperbaric oxygen therapy keep changing how we approach even these seemingly old diseases. Perhaps, listeners might want to look more into current hyperbaric research or even the history of how this therapy came about. It's quite a story. Thanks for joining us for this deep dive.